All right, well, thank you for having me. I'm gonna move these to the side because I think I'm mic'd. All right, so I have been tasked to talk about genetics, genomics, and emerging diagnostic tools. So I'm actually gonna present this in a case-based format to try to include these various diagnostic tests so we can sort of understand how they're used in practice. So I didn't catch them all, so at the end I'm gonna kind of review a few of the diagnostic tests that I was not able to include in the case. So we're gonna start off with a 41-year-old premenopausal woman who is BRCA positive. She has a 2-centimeter invasive ductal carcinoma. So I'm gonna go through the case in more detail, but this is just gonna kind of go through and highlight some of the things that I'm gonna talk about. So if we start with the case study, 41-year-old premenopausal woman, she notes a palpable abnormality and goes to her doctor, and they order a diagnostic mammogram and ultrasound. They ultimately do an ultrasound-guided biopsy, which demonstrates the invasive ductal carcinoma. It is grade 2, so if we remember our pathology report, grade 1 is the least aggressive, grade 3 is the most aggressive, so grade 2 is in the middle, considered a moderately differentiated cancer. And it is highly estrogen positive at 99%, progesterone positive at 50%. So we know this is a very hormonally driven cancer. So regardless of any other treatment that she's gonna have, we know that anti-estrogen therapy is gonna be a huge part of her care, and it's gonna reduce her risk of recurrence by at least 50%. So again, hormonally driven cancers, regardless of chemotherapy, tend to derive the greatest benefit from the anti-estrogen therapy. And she's HER2/neu negative, she's +1, so that's immunohistochemical testing, and 0 and 1 are considered negative, 3+ is considered positive, 2+ is borderline or equivocal, so they reflex to FISH testing, which is in situ hybridization. So if you see a +2, you should always see an accompanying FISH result, and that will tell us if it's amplified or not, is it positive or negative. So you can have a +2 that you will not use Herceptin in because the FISH may come back negative. So the FISH test trumps the IHC, especially if in a +2. She comes into our multidisciplinary clinic for evaluation, and the size on the ultrasound is 5.1 centimeters. So step 1, lots of things to think about in this case. I already kind of told you she's BRCA positive, but I shouldn't have done that. She's a young premenopausal woman. She has a family history of breast cancer, pancreas cancer, and colon cancer. So right there, again, even without the family history, seeing that she's young and premenopausal with breast cancer, that is already a step in the direction of saying, you know what, she needs genetic testing or should at least be counseled on it and then can make her own decision. So we talked to her about the risks and the benefits and the limitations of genetic testing. Panel testing is recommended, so there's multiple companies, Myriad, Invitae, multiple companies. We usually recommend a consultation to our genetic counselors, and that way they can sort of have this conversation with them and discuss, again, the pitfalls, what will they learn from it. It can sort of, add to anxiety to know you have a genetic abnormality, but it's just at least informative to the patient to say, what do you want to know and how much information do you want to get? And also remembering that not just BRCA is associated with breast cancer. There are other genetic abnormalities that can be associated with breast cancer, such as the CHEK2 mutation, ATM mutations, PALB2 mutations, a whole myriad, and there's so many new ones that are coming out. They may not always change management, but it can definitely predispose you to a higher risk of breast cancer, as well as other cancers. So this is an example of an 84-gene panel on Invitae. You can see here BRCA2 has a pathogenic variant associated with it, and this is why she's BRCA2 positive. We can also see below that there's a variant of unknown significance. So again, we don't treat VUSs as a positive result. They are unknown. So we keep them in the database, and oftentimes we review them, or I send a message to our genetic counselor, hey, any more information on this sequence of this gene? But a variant of unknown significance is not treated as a positive result. So if you have a variant of unknown significance, even with a BRCA1 or BRCA2 or a PALB2, any of those, it is not considered that the patient has a BRCA gene mutation. It is an unknown significance. So we know that there's certain sequences that are pathogenic and have been studied. So again, BRCA positive, we know it increases the risk of a second breast cancer. So this goes into the discussion with the patient saying, we want to treat this breast cancer that you have, of course. That is the most important thing. But we also want to think about what is your future and what is the risk of having a second or contralateral breast cancer. And you can see the numbers here, 3.6% for women annually. So this is an annualized rate with BRCA1 and 2.6 with BRCA2. The total risk of having breast cancer in the opposite breast 10 years after diagnosis is 32% for women with BRCA1 and 21% with BRCA2. So just remembering it. Some of this is also age dependent. If they're older when they have the diagnosis, they have less of a risk of having a second cancer. So obviously genetic testing is very important in the right population and requires an intense discussion. And just lastly on this, this just tells you your lifetime risk for BRCA1 and BRCA2, remembering that ovarian cancer risk also goes up with these genetics. So as we go back to the case study, the patient does move forward with a bilateral mastectomy. She's young, she's premenopausal, she has a high risk of a second cancer potentially, and she ends up with a T3, T stands for tumor, 3, because it's greater than 5 centimeters. N stands for lymph node. It's 0. She has 0 lymph nodes that have cancer. And M stands for metastasis. So, and then IDC is invasive ductal carcinoma. She has a T3N0M0 invasive ductal carcinoma. And if we remember, she's estrogen receptor positive, HER2 negative, and she's lymph node negative. So now we're saying, okay, she has a hormonally driven cancer, but it's larger, it's lymph node negative. We want to see what additional adjuvant therapy do we want to move forward with in order to reduce her risk of recurrence. So remembering there's 2 kinds of recurrences. There's local recurrence and there's distant recurrence, and we want to protect against both. The ONCOTYPE test is looking for, it's a 21 gene assay that looks at the tumor tissue itself, and it predicts for a risk of distant recurrence specifically. So here is an example. Her ONCOTYPE comes back high at a recurrence score of 32. What does that mean? It means that we can see in the boxes next to the big 32 that she has a 20% risk of distant recurrence, so distant only, over a 9-year period of time, assuming that she will take the anti-estrogen therapy. The anti-estrogen therapy gives you about a 50% risk reduction in recurrence. And so that 20% incorporates and already includes that benefit. So without that therapy, then that number would potentially double. We can see in the box next to it that she would derive significant benefit from adjuvant chemotherapy. She has a greater than 15% chance of responding to chemotherapy and decreasing the risk of recurrence. These were done, the predictive value of chemotherapy was done in one study, and the prognostic results were done in a different study, so you can't quite say 20 minus 15 is her risk of recurrence. It doesn't quite work that way, and I'm going to show you another slide that explains that, because they were done in cross studies, or 2 different studies. And then you can see down below that age greater than 50 versus age less than or equal to 50, the benefit of chemotherapy is different because of age. So this would be a traditional OncoType report. This is not taking the recurrence score of 32, but for illustrative purposes, you can see the graph here, and you're seeing that the dotted line is tamoxifen plus chemo. The solid line is tamoxifen alone. So where the big blue arrow is, you can see that would be around a recurrence score of 32, which was the example I gave on the previous slide. And you can see the space between the solid line and the dotted line is actually the benefit of chemotherapy. And so you can see that you can't quite use those numbers that were on the previous slide. And so this just shows you in this situation that the addition of chemotherapy to tamoxifen is going to be helpful. So when we look at the ONCOTYPE, this was one of the first gene expression profiles that came out. It's on the NCCN guidelines. It's the most heavily validated. Many of you may have also heard of MammaPrint. That's a great study or great test as well. It looks at 70 different genes. I think it's more used widely in Europe. It's gaining some momentum here. It does not have as much predictive validation in terms of how well the treatment will work or how much it reduces the risk of recurrence as compared to the ONCOTYPE. But the ONCOTYPE provides both a prognostic signature for outcome as well as a predictive value to chemotherapy. So really understanding that it's both of those things, and that's really important for patients to say, okay, to be able to tell patients this is the risk of recurrence, but this is how much benefit you're going to actually derive from the treatment, and then these are the toxicities and side effects of the treatment. We know that we use ONCOTYPE for estrogen receptor positive tumors only. So if they're HER2 positive or estrogen receptor negative, we do not utilize this test. And we can use lymph node positive disease as well. That's a little nuanced. We know for sure in postmenopausal women, if they have 1 to 3 positive lymph nodes, we can utilize this test. It all looks at the biology of the tumor. Sometimes a tumor could be there for a long period of time, so it's moved onto the lymph nodes, but the biology of the tumor may still be a less aggressive tumor that would not respond as well to chemotherapy. Remember, chemotherapy works on fast-growing cells, not as much on the slower cells that are highly estrogen positive with low Ki-67s, which are the tumor proliferation rates that get reported out on the pathology report. And we also see that the effective chemotherapy can change based on the age, and that demarcation is age of 50. So this just goes into some data. Looking at the TAILOR-RX trial, I just want to quickly draw your attention to that. Initially, when ONCOTYPE came out, they had a low risk of recurrence, an intermediate risk of recurrence, and a high risk of recurrence. So we didn't really know what to do with patients in the intermediate risk. We didn't know if they would derive benefit from adjuvant chemotherapy or not. We knew low risk we felt comfortable with. We knew high risk. And that middle risk, we said, okay, we need to do a trial to say, all right, where is the cut point? Where along the graph can we say, all right, you do get benefit and you don't get benefit? And we realized based on this TAILOR-RX trial, they randomized these women to endocrine therapy and then endocrine therapy plus chemotherapy, and they found that that point was around 25. So if someone has an ONCOTYPE score greater than 25, then they typically derive benefit from adjuvant chemotherapy, and less than or equal to 25, they do not. Some caveats to that, age under 50, but that is the general rule of thumb. And we also have observational data to support these numbers as well. So she does move forward with chemotherapy because she had a high risk of recurrence. And we reviewed fertility options. She has 2 children, but she was considering having another child. And I think you guys already had a talk on oncofertility, but just reminding all of you that we do want to have these conversations with our patients, because when you start chemotherapy, it can put you into a permanent menopause because it does affect the ovarian production of estrogen. And depending on your age, you have a higher or lower chance of sort of going back into the premenopausal state. So just remembering to have these conversations with our patients. So we did refer her to oncofertility. She elected at this point to not proceed with that, and she started chemotherapy with Taxotere and Cytoxan for 4 cycles. One other note on the ONCOTYPE test, the benefit from chemotherapy, it did not define which chemotherapy regimen to use. So we say any chemotherapy regimen would give that benefit of that greater than 15%. She completes her chemotherapy. She also then moves forward with the bilateral salpingo oophorectomy because she's BRCA positive and she has an increased risk of ovarian cancer. She then starts anti-estrogen therapy with anastrozole. That is an aromatase inhibitor. It inhibits the conversion of pre-estrogen to estrogen in the adrenal glands, because even though she's postmenopausal and has had her ovaries removed, we are still producing some estrogen in our bodies through fat cells, through the adrenal gland. And reducing that level of estrogen from low to no basically does decrease that risk of recurrence of metastatic disease by over 50%. So just remembering, even if you remove the ovaries, many women ask, oh, I'm postmenopausal, I'm not producing any estrogen, why do I need to go on any medication? And that is the reason why. We always want to follow baseline bone density tests because we know these medications decrease bone density. She does have her routine labs, physical exams. We're checking her review of systems. And she's also started on a bisphosphonate, Zometa, as prevention for her bone density issues, as well as decreasing her risk of recurrence of her breast cancer. So this kind of alludes to ctDNA testing, and I know Dr. Patel talked about this as well, and I do believe that this is the future. So we decided to enroll her on a trial. There's 3 that are going on. I think ZEST trial actually just closed, and it looks at monitoring with ctDNA, so circulating tumor cells. And it is a tissue-based test. So you need their original biopsy or a biopsy of a metastatic site, and they make a blueprint. They look at 16 different mutations within that tumor tissue, and they then marry it with the blood sample that's given, and that's how we can potentially detect circulating tumor cells in the blood specimen itself. So this can be a way to follow patients because it can show it can show a recurrence well before a scan would show something or before it would be detected on a CEA or a CA2729 and a traditional tumor marker test. So in February of 2023, Natera's Signatera test, it's also a minimal residual disease test, as Dr. Patel alluded to as well. It did meet coverage requirements for the adjuvant setting and also for recurrence monitoring in patients with stage 2B or higher breast cancer, including all subtypes. So hormone receptor positive, HER2 positive, estrogen receptor negative, all subtypes. They say, okay, if you have a 2B stage or above, you can follow with this blood test every 6 months to try to assess for an earlier recurrence. So it is a very mixed thing in terms of whether patients want this or not. It can give comfort, but it can also create anxiety. And I think that's what we're sort of dealing with. We're trying to figure out where does this fit into clinical practice that makes sense and can actually help the patient. So we can only imagine the controversy. So this is just sort of an example of a patient who had a Signatera test drawn at the time of diagnosis and then had neoadjuvant chemotherapy, so had chemotherapy prior to surgery, and we can see that her circulating tumor cells decreased with treatment, which is a good prognostic sign, and then she had surgery, and then you can see those open circles are no circulating tumor cells. So between the neoadjuvant chemotherapy and the surgery, she had 0 circulating tumor cells, which is a very good prognostic sign, and that can be one way to utilize this test. So how does it work? I sort of described that. It's controversial, right? I mean, if you see that you have a positive test and you do a bone scan and a CT scan and nothing shows on those scans, what do? Do you treat the positive test thinking, okay, it's just a matter of time, and does treating earlier really help? So these are the different things we're looking at. Does it replace scans? Would you say, I'm just going to follow the ctDNA now, I'm not going to bother with interval scans? And then how do we interpret these? And I know I'm running out of time. So we did a CT scan. She actually had a CT chest, abdomen, pelvis. It was negative, but she did have bony disease. So that was shown on the bone scan. We did a biopsy and sent it for pathology because you always want to re-biopsy metastatic sites. You want to, number one, prove that it really is cancer. You want to make sure it's the same cancer, and you want to understand the biology of this cancer. Is it the same as what she was diagnosed with? So it ended up that this one was estrogen receptor negative. So she started off with estrogen receptor positive. This was estrogen receptor negative, HER2 negative, progesterone receptor negative. We sent it for foundation testing, and foundation testing is testing to look for molecular targets. So it can help guide us in our treatment of metastatic disease. So we can look for a PD-L1 abnormality, like Dr. Patel was talking about. Would this patient qualify for immunotherapy, and would it help them? We can check, sometimes we pick up BRCA mutations or PALB2 mutations in people we have not done genetic testing on. We can find an ESR1 mutation, which is an estrogen receptor mutation that tells us they're not going to respond to the anastrozole any longer and they need fulvestrant. So there's a lot of benefit to doing this testing, and we typically do it at the first site of metastatic disease, especially in breast cancer. And so for treatment for her, we based it on the Olympiad trial. I'm not going to go through this whole slide, but it basically shows that there's a medication called olaparib, which is an oral agent that works really well in patients who have BRCA 1 or 2 mutations. So when you have the BRCA gene mutation, you do not have the DNA repair mechanism that a normal person would have. I guess I would put it that way. So you can have a higher propensity to develop cancer. When you use these agents, they are called PARP inhibitors, and they sort of repair the DNA mechanism that is lost. So then they can repair the mutations and then decrease your overall burden of cancer. So that is what we ended up doing in this patient, and she had a very nice response to that, and she continues to respond. The response with olaparib tends to be better in estrogen receptor negative patients. So she has really shown that. So just to review what we covered, the ONCOTYPE test is both predictive and prognostic. That is for adjuvant therapy guidance. So a patient has surgery, and then you do that test if they are lymph node negative predominantly and estrogen receptor positive, HER2 negative. And that tells us, would they benefit from adjuvant chemotherapy? There's MammaPrint testing. That is a 70 gene panel that probably has more prognostic implications, less predictive implications. We talked about genetic testing and panel testing. And then Signatera, which is a circulating tumor cell, or looking for cell-free DNA as a means to monitor a patient who has metastasis, or look at somebody who has neoadjuvant, who is going to have neoadjuvant chemotherapy. And because we know that that is also prognostic if they do go down to 0 circulating tumor cells. We talked about foundation testing. Guardant 360 is another company that also does molecular testing. So some practitioners prefer that versus foundation testing. It doesn't matter. They're both really good. One caution really quickly on those tests: if you don't have a lot of burden of metastatic disease, so if you have very little disease and you do that testing, it may not come back positive. So you might be missing a mutation because there's just not enough cells in circulation to find it. So if you have continued progression and you have a negative test that does not show you any targets, you should repeat that test upon further progression of their disease. And lastly, I just want to mention this test called breast cancer index test. It is a test actually that looks at whether a woman would benefit from extended adjuvant therapy. So really quickly, we know 5 years is sort of the minimum in terms of tamoxifen and an aromatase inhibitor. Some people, we say they need 10 years of therapy, right? How do we make that distinction? Well, this is another test that actually tests the tumor cells itself from the original diagnosis, looks at a different set of genomic or genetic variations within that tumor, and tells us what is the risk of recurrence from years 5 to 10, so not 0 to 5, but from years 5 to 10, and do they derive any benefit with extended treatment for another 5 years of anti-hormone therapy. Again, really important because these women really do unfortunately suffer with some of the side effects of these medications, and they're just having to make choices between quality of life and length of life, and that's really hard. So anyone that we can avoid over treatment on, I think that's really important. So I think that's it. Thank you so much. Thank you.